Dr. Ipsita Das has a topic on an unusual case of lower canaliculus laceration following dog bite managed by stent placement.
Good morning everyone. I'll present an unusual case of lower canalicular laceration following dog bite managed by stent placement. The informed consent was taken from the patient and there was no conflict of interest and no financial support. Lower eyelid lacerations resulting from dog bites present a unique and challenging clinical scenario due to their delicate anatomy and potential aesthetic and functional consequences. A 19-year-old male presented to the ophthalmology emergency department with active bleeding from the medial canthal area of his left eye following a dog bite. The patient complained of epiphora, excessive tearing from the affected eye. On examination, the patient had a 2 cm 3 mm laceration at the medial part of the left lower lid area with injury to the canaliculus. Visual acuity was within normal limits in both the eyes. There was no signs of other ocular injury and the anterior and posterior segment of both eyes were within normal limits. The patient was diagnosed as a case of left lower lid canalicular laceration. The injury site was washed with adequate saline water. The patient was managed with conservatively initially with rabies immunoglobulin, anti-rabies vaccine, injection tetanus toxoid, oral antibiotic, oral analgesic, antibiotic drop ointment for local application. The patient was taken to operation room for repair. After local anesthesia, the wound was carefully explored to assess the extent of the injury to the surrounding tissue, including the canalicular duct. The 24-gauge cannula was introduced as canalicular stent in the affected lower canalicular duct. Syringing revealed full patency after the stent placement. The stent was fixed with the lower lid to avoid expulsion of the stent and irritation on the corneal surface. Primary repair of the left lower lid laceration was then performed meticulously to ensure optimal wound closure and alignment. The post-operative period was uneventful with no signs of infection or wound dehiscence. The patient epiphora gradually improved over the following weeks. The visual acuity remained unaffected. Patient was followed up at 2 and 4 weeks post-surgery with excellent cosmetic and functional outcome, and there was no watering from the left eye. The cannula was removed at 12 weeks post-operatively and syringing revealed full patency. The lower eyelid lacerations with canalicular injury due to dog bite are relatively rare, and early recognition and appropriate management are essential to prevent long-term complications such as chronic epiphora or lacrimal drainage system dysfunction. The use of 24-gauge cannula as canalicular stent followed by plastic repair of the lower lid laceration facilitated to restore the continuity of the duct and proper tear drainage. Eyelid lacerations with canalicular duct injury require prompt evaluation and surgical repair to prevent potential complications and optimize the patient outcome. This case report adds to the existing literature on the management of ophthalmic injuries and emphasizes the importance of providing comprehensive patient care. Thank you.
Use of 24-gauge cannula, since it doesn't have got that top like in mini Monaco tube, won't it protrude and then it will rub at the conjunctiva? That thing?
Actually, in a hospital setup, it is like more cheap and it is easily available. So, we used it, and the diameter of the canalicula is almost similar as that yellow 24-gauge cannula. So, it is like causing less harmful, minimally harmful for the canalicula. So, we used.
That we agree, because earlier when mini Monaco cannula was not available, everybody was using these stents. But then since it is available and it is not expensive at all, the Indian made one by Orolab is very good, and it's not expensive.
Okay.
It provides internal fixation.
Okay.
Yeah, because it has this bulbous tip. It gets into the puncta and it gets fixed by itself, and it's very easy to insert as well. Yeah, so you could try using it because it's very easily available and inexpensive.
This cannula is very notorious for coming out. Even after 10 days or 12 days, the suture, anchoring suture gets loose, and the patient comes after 15-20 days, the cannula bahar aa gaya. So your whole exercise is...
Yeah, but if you use alternative mini Monaco, then this chance of extrusion that sir is mentioning is much less, because it is fixed anyway at the puncta. So it has a punctal plug.
Oh, thank you.
So one more thing, so if there is a laceration like this, it is very difficult because there is edema and all that. It is very difficult to identify the medial aspect of the canaliculi, the sac part of it. So how can we help it?
There are many maneuvers. One is that you look at the wound after cleaning very nicely with an operating microscope under high magnification. More often than not, you'll be able to find out the cut end. Suppose it is not possible, put in a drop of phenylephrine. So there is pericanalicular blanching. It will look like a pale white cut structure. That is the one. If still you cannot make out, then there is modified Morrison technique where you pool saline in the medial canthus and inject air from the upper canaliculus. If even that fails, then there is this pigtail probe. Pigtail probe is quite traumatic, but the modified pigtail probe with a very gentle curve and a nice rounded tip that is available, you insert it from the upper canaliculus if the lower canaliculus is torn, and it comes out through the medial cuthead. So once you identify it, the job is nearly done. Threading the cannula is not a problem.
Just to add on to it,
You can, yeah.
can use
Fluorescein
blue.
stain is also used.
Yes.
It stains the cuttage of the canaliculus. Also, you can inject a fluorescein tinged saline from the other canaliculus. But you should actually block so that it doesn't flow through the normal NLD, rather comes out through the cuttage. Thank you.
Thank you.